Welcome back. Up until now in the course, I've described the cancer problem and its causes, how cancer develops in the body. We've looked inside cancer cells for their secrets, then described the science behind old and conventional cancer therapy and new therapy based on knowledge inside of cells. I want to now circle back to where we started in the course, to populations, and look in the next two lectures at screening and prevention. My story is about Susan. Susan was called back to her physician's office a few days after her annual checkup. The doctor said, "Your cervical smear looked abnormal when I looked at it after you left the office. And just to be sure, I had a pathologist read it as well." Pathologist concluded what I did too. It confirmed that there are precancerous cells in your cervix. Susan felt numb when she heard the word cancer. Sensing her discomfort, the doctor reassured her, no, the cells were in an early stage on their way to cancer. They're not yet full-blown cancer. And they can be removed by a simple surgical procedure. 2 weeks later, the surface layer of Susan's cervix was removed, and there was no cancer later on. So here is what was done. Here is the tissue of the cervix. Here is the uterus itself. And here are the abnormal cells, the precancerous cells on the cervix. So you can just begin, you can see that if those cells are detected, the cells could be removed from Susan. Now Susan was fortunate. Her medical exam included a Pap test named after George Papanicolaou. The cells lining and shed from the cervix are examined for abnormalities. George Papanicolaou was born in Greece, the son of a physician, and educated first in University of Athens, where he got his medical degree, and University of Munich in Germany, where he got a PhD. He was part of a great migration of people from Southern and Eastern Europe to the United States in the early part of the 20th century. And in 1914, he found himself as a young professor at Cornell Hospital in New York. And he was interested in all types of women's diseases, and so he decided to study the ovarian cycle in an animal model for the human ovarian cycle, namely guinea pigs. They undergo the same cycle on a monthly basis as do human women. He looked at smears of cervical cells. He looked at cells during the ovarian cycle that he could just get by a Q-tip that were on the surface of the cervix, and he found that they changed like clockwork. By the 1920s, Papanicolaou had extended these observations of cell changes in the normal cycle, monthly cycle from women, to humans, and that the cells changed shape, and he could almost say what stage a woman was in her ovarian cycle by what those cells looked like. By chance, one woman he examined in the late 20s had uterine cancer, and her shed cells looked really, really different. The cells that she shed from her uterus looked totally abnormal. Over the years, next couple of decades, he saw several thousand other cancer cases of uterine cancer and cervical cancer, and the cells really were abnormal. And at that point, Papanicolaou became quite famous because he had a way of diagnosing the presence of uterine or cervical cancer by looking at the cells that were shed. In some cases, however, the cells didn't look that malignant. They looked like they were on their way to being cancerous. And he asked the questions, are these cells precancerous cells on their way? In 1952, he organized a very large clinical investigation. He wanted to find a lot of people with precancerous cells, and then he would treat them as Susan was treated. And so he examined the Pap smears of 150,000 women. You can imagine a lot of microscopes were involved here, in the Memphis, Tennessee area of the United States. And of those 150,000 women, he found 555 who had cervical cancer based on what the cells looked like, and they went in and they were treated. 557 had precancerous cells. They weren't cervical cancer, but they kind of looked like they were on the way. And so Papanicolaou and his colleagues treated these women who had no symptoms, treated them by removing the cell layer, just had been done with Susan, and then followed them over the next decade. None of them got cervical cancer. He had done a screening test for cervical cancer, and screening had prevented the development of cancer. By 1960, it was pretty clear that screening was going to be very useful for cervical cancer, and so it was mandated by law in Scandinavian countries first and Canada, where there's socialized medicine. So everyone, all women got cervical cancer screening at intervals, and there was a great decrease in cervical cancer. So here is the the incidence rate of cervical cancer, incidence rate over a year, beginning in 1960 and ending in, well, for all intents and purposes, by 1980, for 20 years. And you see that for many countries, it went down by 2/3. Terrific. The United States adopted this test as well, and both the incidence and mortality to cervical cancer went way down during the late 20th century. This is a terrific story because it shows how science led to a screening test which led to a significant reduction in incidence and mortality of cervical cancer. In this lecture, I'm going to describe cancer screening. First, I'll describe what screening tests are. Then I'll describe 3 examples of screening. I've already described the 4th, cervical cancer screening, and its success. Now let's apply those types of investigations to breast cancer, colon cancer, and prostate cancer. First, what's screening? The World Health Organization defines screening for disease, and here we're talking about cancer, as the identification of unrecognized disease by the application of a rapid test. Repeat, identification of unrecognized disease. You don't know you have it, and the doctor doesn't see it, obviously, by the application of a rapid test. Screening for cancer in the United States and for most countries in 2012 for 4 cancers that are most common cancers that are screened are cervical cancer by a pap smear, breast cancer, mammogram, colon cancer by colonoscopy, prostate cancer by a PSA test, and we'll talk about all of these as time goes on. What does screening tests do? Screening tests sorts out apparently well people who probably don't have a disease that they can't tell they have from those who probably do have the disease. Remember, I said probably do and probably don't. Unless the test is perfect, the word probably has to be in there, right? And as you're going to see, almost all tests we have for screening are not perfect. Screening is not a diagnosis. A screen, when you detect something that's probably cancer, has to be followed up by biopsies and chemical tests, etc., with cells, etc. Now, with molecular screening, which is just starting, and we're really not going to discuss it in enough detail to warrant its inclusion because it's so just beginning, DNA screening, etc. The more we do DNA analyses, there may be more ability to diagnose cancer with screening, but we're nowhere near that. We're not even taking the first steps toward it. There are 2 requirements for usefulness of screening. Let's look here at the development of a tumor. We begin with a layer, this might be a carcinoma, like cervical cancer. Here's a surface layer. The surface layer then begins to invade, and then it becomes more invasive. This is normal tissue, and now we end up with clinical disease. The first thing we need to know about whether a screening test is valuable is there a recognized pre-malignant state? Is there a point in the early development of cancer that we can see in an easy screening test and say, well, that's an early cancer, right? Papanicolau and the cervical cells that look like they were just becoming on the way to cancer. Second, of course, we want to know, is the early detection going to do you any good? It does me no good to be told, yes, I do a screening of a whole large population and to tell the certain proportion of people, yes, you have lung cancer and you will die in 6 months. That's not useful. What's useful is that treatment will result in an improved outcome for people. The third aspect that's beside these 2 criteria is you want to screen the right population. it doesn't make sense to do mammograms on men. Now, men can get breast cancer, but it's a much, 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 much rarer cancer than in women. So it's not really cost effective to screen every man for breast cancer. What are the best types of cancer for screening? The best types of cancer for screening are those with a reasonably high incidence of a population at risk. If a type of cancer only has 1 in a million in a population, that means we're screening 1 million people at great expense to detect one cancer. So we need a reasonable incidence. Second, there should be a long preclinical phase where treatment can begin. If we have a screening result and it takes 2 weeks to get the result, and in those 2 weeks the tumor goes crazy and starts, the patient succumbs, that's not useful. So you want a long preclinical phase when treatment can begin to alter the course of treatment. And of course, you want the test to be easily done, and you want it to be a modest cost that's not prohibitive for a healthcare system. What are the detection methods for screening? They include feeling, palpation it's called, looking for lumps at the breast or prostate. So a physician or trained person can look for lumps or thickening. Secondly, of course, are internal methods, X-rays like a mammogram or an endoscope for looking at the stomach cancer from here, and for endoscopy, colonoscope for colon cancer. So you can look internally and externally using X-rays. Third, of course, are biochemical, molecular markers. So we can look for a marker, a chemical that's unique to the cancer cell, hopefully. And if we can detect it even in blood, blood tests where cancer cells are leaking it out into the blood, that would be very useful. The costs and benefits of any screening tests are going to vary with the kind of test. So here they are on a balance, okay? What are the costs of screening? They include financial cost. How much does it cost? You know, if a screening test costs $10,000 per person and we're screening 10 million people, that's a lot of money. So cost, we want to know is a cost in terms of morbidity to the person. Discomfort, but also possible perforation of the colon, for example, if it's an internal test. Radiation, right, is always a risk for a mammogram. So morbidity. And finally, acceptability. Will the patient show up for the test? Some people don't want to show up for a colonoscopy. The benefit is of course an increased survival, decreased mortality. So costs and benefits. Economists have to look at this as well, right? How much money is saved by early detection, as well as lives, and how much does early detection cost per case found? As I said, if it costs $1,000 per screening test and there's 1 in a million, we're going to have $1 billion of cost to detect one case. Screening tests are not perfect. As I said, they're not diagnostic, they're not perfect. Question is, how good is a test? And there are 2 general criteria for evaluating screening: reliability and validity. First, reliability. That means reproducibility. The consistency with which a test gives the same results. That can be within-person variability. You have the same person read the same pap smear on 2 different days, right? Like the doctor reading 2 different pap smears, the same slide on 2 different days, saying, yeah, that's precancerous. Or between people variability. Remember in our opening story, the doctor called in a pathologist, so 2 people read the same screen, and that's usually the case, by the way. 2 doctors read it to come up with the same result. 2 different people looking at the same pap smear. But you know, if you get the same result on 2 days, or if 2 doctors both agree that it's cancer, doesn't necessarily mean it's valid. They may be wrong. The voters sometimes are incorrect, even though they think they have all the information. So now we come to validity. Validity is asking the question, does the test actually distinguish people with cancer and those without? Validity has 2 components. First, sensitivity, and second, specificity. First, I'll deal with sensitivity. Sensitivity, the proportion of people with the disease who test positive. You want to measure sensitivity? Give the test, the cancer screening test, to people you know by other means are actually positive, that have the cancer. Anyone testing negative is a false negative, right? They have cancer, but they're not testing. They're not coming up with a test. So for example, for pap smear, sensitivity is 95%, which means 19 out of 20 cancer cases are detected. However, we got a false negative there, right? 1 out of 20 women walk out of a pap smear, the doctor looks at it and says normal, but unfortunately the cancer goes on to develop. And I'm telling you now, pap smear test is a very good test, but it has a 1 in 20 error rate. The second aspect of validity is specificity. Specificity is the proportion of unaffected people, don't have the cancer, who test negative. That should be everybody who doesn't have cancer. That's a much larger group of people because the number of people with cancer is much smaller than the number of people and much people without. So here you can take a person who doesn't have the cancer, give them the test, and hopefully the person will test negative. If the person tests positive, then it's a false positive. They have to be followed up and biopsied, and pathologists get involved. The person gets very anxious. They might have cancer, and then actually they don't. The specificity of a pap smear is over 95%, which means very few occasions. There are very few occasions in which doctors seeing a positive test on a pap smear, which says that person has precancerous cells, don't really. Okay? False positives are a burden on the medical care system, of course, because the more false positives there are, the more follow-up there has to be for no particularly good medical reason. There are some cancers for which screening is not useful. For instance, no detection method for early cancer, like in pancreatic cancer, unfortunately, and no localized stage for early treatment, like leukemias that develop in the bone marrow. There's nothing obvious about a pre-leukemic cell sometimes. So let's look at a couple of screening tests. First, breast cancer screening, and I say it's partially successful. The 5-year survival at diagnosis of localized cancer in the breast is over 90%. It's over 91%. It's pretty high. If the cancer has spread beyond the breast, it's 70% 5-year survival. So obviously you want to get it early. You want to get it when it's local. The screening tests typically done every 1 to 2 years are 3. Breast self-exam. The second one is clinical breast exam, and the third is mammogram. So let's look at all 3 of them. First, breast self-exam. Breast self-exam has a woman carefully examining her breast for lumps. Okay? The sensitivity is 21%, which means it misses 80% of breast cancers. The specificity is 30%, which means 70% of the time the woman feels the lump, it's not breast cancer. Many studies now have been done on large numbers of women who on the breast self-exam. To give you an example of how that's done, you take a bunch of Chinese factory workers in Shanghai, and you got thousands of women in the factory, and for a month, every day, half the women are sent for breast cancer self-exam training. They get really good at it. The doctors show them exactly how to do it. They get tested and are really good. The other women sit around and read a book. Okay, that's the cohort study. It's the people learning and the people not learning, and then the result is going to be breast cancer and how many people detect breast cancer. Okay, well, here's the result of this huge analysis of many studies. What we're looking at is breast cancer, or whatever the criterion is. Here's the good one, less. We want less of it, so you want to be left of the 1 here. And here is more. 1 means the same. The people who learned breast self-exam are the same as the people who didn't learn. So, what happens? Look at this. Doctor visits, more of them. Yep, the women were finding lumps. Who looked for lumps. Biopsies for cancer? Yep, more of them. Breast cancer diagnosis, actually, no change. Breast cancer death, no change. Some countries, such as Canada, do no longer recommend self-examination. US still does. It's probably on the way out. The second type of testing for screening for breast cancer is called a clinical breast exam, done by a physician or well-trained nurse. And this is getting small tumors, usually greater than 1 millimeter in size, dimes. And so what they do is they look at dime-sized regions this big, serially examined very carefully in the breast, all the way to the ribs. Sensitivity here, 60%. They miss 40% of cancers. Specificity is pretty good. When they find one, it's definitely cancer, 95%. Clinical breast exam results in maybe 10% of all breast cancer diagnoses. Much more widely used are mammograms. Mammograms are going to detect small tumors. They're pretty cheap. They use a small amount of radioactivity. Tens of millions of women get these every year. The sensitivity of mammograms ranges between 80 and 90%. It's higher in older women, and the reason is younger women's breasts have more fat, and the fat looks white on a mammogram just like the tumor does, so it becomes hard to distinguish the tumor from the fat. Older women's breasts have less fat, and so it's easier to detect, a little more in the 90% range. That's pretty good, 90%. Specificity, greater than 95%. Very few false positives. Large study was done in Europe between 1982 and 94. Eight studies were combined, over 500,000 women, looking at mammogram versus no mammogram, and the end result was looking at breast cancer mortality. They put them into two groups, ages 50 to 79 and ages 40 to 49 for screening. So for age 50 to 79, the result was spectacular, 20% reduction in breast cancer mortality by early detection, by screening. That's terrific, by mammogram. For women 40 to 49, there was no reduction, which says on this basis, and at this time in the 1990s, the recommendation was don't screen women in their 40s because it's not going to do any good, or good statistically enough good to warrant screening on an annual or semi-annual basis. This set off a huge debate over 15 years. The U.S., as of the time that I'm lecturing today, and the U.S. government uses a 2010 recommendation that says the following. For women aged, and this is the U.S. Preventive Services Task Force, which is a task force composed of experts in screening, experts in breast cancer, and members of the public, and members in industry. It's a wide-ranging organization. For women ages 50 to 74, it says screen with a mammogram every 2 years. And the benefit of screening is a grade B, a good, decent benefit. For women ages 40 to 49, it says do not screen routinely, individualized decision to begin biennial screening according to the patient's context and values. You know, a patient who says, I'd like not to die of breast cancer. That's a wonderful value to have. So the statement's not an interesting one to me, but essentially it's individualizing this decision, which is a strange thing to do because we want a recommendation as to what to do. So enormously controversial, whether to have screen women in their 40s. However, the recommendation not to screen women in their 40s or to screen was discussed in Sweden. And different counties in Sweden decided, some of them decided, yeah, we're going to screen women in their 40s. And the other counties said no. 1 million women were set up now in essentially a cohort study that said 1 million, half of the women were screened in some of the counties that were screening in their 40s, and some were not. 16 years of follow-up in ages 40 to 49 for screening for breast cancer. So here are the counties. There's the map of Sweden, and the dark ones are the counties that were screened, and the light counties weren't. And here's the result. This is looking at the cumulative incidence of cancer, of breast cancer over the time in years, up to 15 years. That is, more cases are piling up. And look, the unscreened women had 26% more cancer than the women who were screened. Now, the way screening resulted in a 26% reduction. Why is this result different than the result previously? Probably because the X-ray machines and the mammogram analysis is better than it's always been. So as a result now, the U.S. and other countries are leaning now toward screening for women in their 40s. Breast cancer, colorectal cancer, colon cancer. I'm saying in my heading, colon cancer screening can be very successful. The 5-year survival for colon cancer is 90% if it's localized, take it out by surgery. If it's spread, it's less than 45%. It's very dismal. You want to get colon cancer, colorectal cancer early. 3 tests are done for colorectal cancer. The 3 tests are blood in the feces, fecal blood sample, sigmoidoscope that essentially takes a tube and looks at just part of the colon, and colonoscopy that looks at the whole colon. First, blood in the feces. In blood in the feces, it's an easy test, and I'm sure many of you have had this test. You take a smear of your fecal matter, they give you a little card to go home with, and you just put it onto a little card, and you're looking for blood that's leaked out by a tumor. So very late tumors have a lot of angiogenesis, and the blood capillaries sometimes will burst, and so some of the blood will get into the fecal matter in the colon. And so blood in the colon may indicate a cancer. The cost here, it's cheap, a couple of dollars. The sensitivity is about 60%. It's not too good. The specificity is 80%. But remember, since colon cancer is pretty rare, the 20% of the people are going to test positive here when they don't really have colon cancer, and they're going to have to be worked up with all sorts of other tests. So it's really not a great test. Sigmoidoscope is a lot better. It's an office procedure, and it doesn't require a hospital, but it only looks at the last part of the colon. The colon has 3 regions. I'm showing my arms here. It's got 1, 2, 3 parts of the colon, and here's the rectum here. It's got 3 parts of the colon. It's only looking at this final part of the colon. Now that has about 2/3 of all of the colon cancer, so you're missing 1/3 of the colon cancer anyway. Sigmoidoscope is less than $50 typically, and for this region it's got a very good sensitivity, 95%. But unfortunately for overall colon cancer, it's got a specificity of 60% because you're missing 2/3 of the colon. It is valuable though, and it will reduce deaths to colon cancer because you're going to detect these. And it's much easier to do than a colonoscopy, which needs sedation and an operating room and the whole colon. And here is a polyp that they can see using this camera that they thread into the colon, and they essentially will snip this off. And you snip it off, you've nipped it in the bud, as they say, and you've taken the precancerous cells out. Sensitivity is greater than 95%. Specificity is almost 100%. They recommend colonoscopy once in a decade, each decade after age 50. There's been a follow-up for colonoscopy so far. It's lowering deaths due to colon cancer more than 85% in people who have a colonoscopy. Now, think about this. If it's done on all men in the United States age 50, 3 million men turn 50 each year. Cost of colonoscopy is about $1,000. So 3 million times $1,000 each, that's $3 billion to do colonoscopies. And if you look at how many years of life are being saved, it's $15,000 per year of life saved. That's pretty good. That's a bargain in medical care to save for $15,000. Many of you have heard of a CT scan. It's advertised widely, a virtual colonoscopy. It's not as good as the real colonoscopy at this point as I lecture, but it's improving very rapidly to detect these small polyps. Here's the problem. I go for a virtual colonoscopy and they're looking at the colon, so I don't have the discomfort of I think, a tube in my colon. But if they find the polyp, they got to go in and do the regular colonoscopy and sniff it out anyway. So it's good most of the time. It's more convenient if it's going to be turned out to be valid. But it's still a tricky thing to do because once you find the polyp, you have to go in surgically and remove it. Prostate cancer screening is questionable. This is a very controversial issue right now. 5-year survival for prostate cancer. Localized prostate cancer is 95%. Removal of the prostate by radiation or surgery. If it's spread, it's much more dismal. It's 22% survival. Prostate cancers are usually very slow growing. It can take years or decades to grow to a malignant state, a highly malignant state. If people do autopsies, look at men who die after the age of 80, very often their prostates are enlarged and they may have precancerous cells. So a dilemma is, if you find prostate cancer at an early stage, should you treat it? Because treatment of prostate cancer can be very aggressive. And it's hard to tell, right, just on the basis of a screening test, if it's an aggressive tumor or not. We just don't have enough biology. Prostate cancer screening, too, I mentioned earlier on in the lecture, a digital rectal exam, and this prostate-specific antigen test looking for prostate cells that are dividing. Digital rectal exam has a sensitivity of, unfortunately, 55%, so you miss two tumors in 5. Specificity is quite high. If you find it by digital rectal exam, it's got a good specificity of 80%. Then we go to the prostate-specific antigen, the PSA test. It's a protein found in cells of the prostate, normal cells dividing and tumor cells dividing. The sensitivity here is about 80%, which is not bad, but still not as good as we would want. You miss 20% of malignant cancer by a PSA test. The specificity is extraordinarily low. It's 33%. 2 times in 3, that person has an elevated, man has an elevated PSA. He's going to have a false positive. They're going to have to be worked up. Sometimes he'll be clinically treated, etc. There's a huge burden on the men and on medical care. It's very controversial because if you have a biopsy that's positive for prostate cancer, what do? that cancer is a very slow-growing cancer. You could treat it with surgery and radiation, which is what's commonly done, and this is the result of PSA screening. A lot more, and you saw earlier on in the course, remember in epidemiology, this great rise in detection of prostate cancers, but the side effects can be incontinence and impotence, a lot of side effects due to surgery and radiation of the prostate. So long-term studies are being done on seeing if PSA screening does any good, and the answer looks to be no for survival so far. So here is years screened and men who were screened and not screened, and there's a quote here from the man who discovered PSA saying, I don't think it's really good. He calls it a public health disaster because we're getting so many men who are being treated questionably with side effects happening, and they're not living any longer than men who were not treated, even though they may have a positive and may have the cancer. So there's a search on. Right now, extremely controversial recommendation by the Preventive Services Task Force for adult males that says do not use the PSA test. So there's a search on for other ways to detect early prostate cancer for screening. It looks like the PSA test may be on the way out. And number one, they're trying to improve the PSA, how that's changed, what the rate to prostate size is. Secondly, they're looking at microRNAs, these RNAs made by cells that may be specific to prostate cancer. There's some evidence that they might be a pattern in blood. Third, there is an RNA, messenger RNA, an RNA in urine called PCA3 that seems to relate to prostate cancer a lot better than PSA. And fourth, there's a metabolite, a chemical called sarcosine that relates to invasiveness. So that may be a way to distinguish prostate cancer that's going to invade and prostate cancer not. Again, leading edge of research, just starting, but it's urgently needed because of the mess we have now at prostate cancer screening and treatment. So I've described screening tests and looking at breast cancer, colon cancer, and prostate cancer. In the next lecture, I'll describe some aspects of preventing cancer.